And the first paper to be discussed is the one which was presented by Professor Marco Cerinic. It's about update on rheumatoid arthritis criteria and therapeutic effectiveness. Anyone wants to ask Professor Cerinic? Can I just start by asking you, Marco, do you think we are having now an influx of biologic agents? And the last one we have with the Janus kinase, small molecules, and so on. How much do you think that the problem of consolidating or initiating a remission and consolidating it in a patient with rheumatoid arthritis who has been given biologic in addition to methotrexate or other DMARDs, how much of the problem was solved? Did we achieve a better progress, or it's, we are more or less going forward and backward most of the time?
For sure, thank you, Samir. For sure, all these drugs together, when they are starting very early, they will give you really the best result. So this is sure. We know this. So when we have a young patient, a young lady with rheumatoid arthritis in the first 3-6 months, and we can hit the disease with combination therapy with synthetic disease-modifying drugs together with biological drugs, we can get the best result out of it. Now, what is not clear to us is for how long shall we keep this patient under this regimen. So this is the problem that we have today, and we don't have yet the real answer to this, because the time is too short from the moment we have started the treatment with biological therapies in our profession. So, we are facing the fact that we have to start, and we know this, but we still do not know for how long shall we keep the patient under this kind of regimen. Or we shall have to withdraw, or we shall have to make gaps in the treatment. We know that when the disease is active, you strike with the regimen, the treatment regimen, you stop the disease evolution, then if you stop after 6 months, 12 months, the disease will relapse. We know this for sure. But then for how long, for how many years, we shall keep the patient under this control, tight control, we don't know. Probably now we are starting some experiences in reducing the drug and making gaps with biological, keeping the synthetic always, and then coming back if something moves with the biological. We are trying to do this, but still, really, we don't have evidence-based data to give a very clear answer to the long run, while in the short run, we know we have to treat this rapidly, even with the new drugs, with the small molecules. So the small molecules and the biological drugs with the antibodies, they are almost similar, very similar. So we know that probably the small molecules will substitute in the future the antibodies, because the antibodies, as you may know, have also an immunological reaction by our bodies. So they will have antibodies against the antibody, and so they will reduce the efficacy.
Yes, but the thing that, like we do in osteoporosis, give the patients drug holidays. But when we do this, we monitor by the bone turnover markers or the BMD. But what about rheumatoid arthritis? How can I pick a patient and I'll say I'll give him a drug holiday or I'll give him intermittent biologic therapy? Are there any criteria? Okay,
there are no criteria, but I can tell you, for instance, as we do, we have now the custom to follow up the patient very tightly. For instance, I showed you some slides with infliximab. Infliximab is a chimeric monoclonal antibody. And you usually treat the patient in time 0, then you restart the treatment every 30, 60 days. So, we are measuring how many days do you need for the patient to start to be symptomatic again. After 30 days he's symptomatic, we treat. After 45 he's symptomatic, we treat. Okay, so the treatment is following the patient symptomatology. And usually, I can tell you, for instance, in spondyloarthropathy, we can arrive to 90, 120 days after the last treatment. So it's almost around 3-4 months later, we can just repeat the treatment instead of 30 days. You know, and this is very controlled approach with the follow-up, very tight follow-up. So the tight follow-up is in reality, in this kind of patient, absolutely mandatory. Actually, just a small note for our audience is that this kind of approach and regimen, we are talking about rheumatoid, but this is extending now to all rheumatic diseases, not only rheumatoid, spondyloarthropathies, ankylosing spondylitis, psoriatic arthritis, lupus. In scleroderma, we are just starting. And the next one, the next frontier, will be in osteoarthritis, as well as is in osteoporosis, we will tell you later. So our job is a complicated job, even with the most simple diseases we have, like, I mean, I say simple, but you can criticize me about osteoarthritis, because we have monoclonal antibodies for osteoarthritis today. So what are we going to do with these patients, also with monoclonal antibodies? High complexity. High complexity. I have just shown you how to behave in rheumatoid and how many items you have to think about the moment you are choosing a regimen. A strategy is a tactic. You have to be in front of the patient and you have to see the future and be able to prevent any side effects and infection, to prevent comorbidities. So it's a real complex job.
Any other questions?
It seems that with the introduction of the recent and new drugs for rheumatology, for rheumatoid arthritis treatment, it is very important to early detect and follow up the changes which you mentioned in your lecture, mainly the minor erosions in the cortex. In what way do you, how can you detect it early and monitor it with treatment?
Okay. You are a radiologist.
Yeah.
You are a radiologist, so you are allowed to judge me, okay? So I'm just a humble rheumatologist. So excuse me if I am speaking about imaging, but you know, we have now ultrasound. We are using ultrasound every day. Now I cannot visit the patient without ultrasound. Me, myself, I'm too old, so I have my young colleagues who work with me, and they are fine ultrasonographers. Why? Because with a good probe in your hand, with a good training, you can catch the very tiny erosions, breakage of the bone very early with the ultrasound, very early. As much as you can catch this with the MRI. Okay? We don't use classically CT scanning, but we use MRI in particular with gadolinium to see the inflammation and how it's distributed, how it's affecting the periosteal bone, and we do the same with the ultrasound. The difference is the ultrasound, you can use it every day at the bedside, and it's very, the cost is very limited. With MRI, the cost is very high, you cannot repeat this every day. So our stethoscope is the probe of the ultrasound for the joints. And I will tell you more about in my talk in this afternoon, because I'll show you how much the stethoscope that is not only listening to the lungs, but also using the probes, how you will also investigate the lung with the ultrasound. Sorry if I just get, thank you.
Can I pose a question to both of you? How much is the personal experience of an ultrasound specialist counts? Would I ask the same specialist to follow up the patients? Does it make a difference if another specialist follows him up? What is the outcome?
Samir, you want to give your thoughts?
As everybody knows here, ultrasound is very much an operator-dependent technique in radiology as a whole. So it depends on the person who is working with ultrasound, and of course, the clinician should have a confidence in the radiologist or the clinician or the operator working with ultrasound. And definitely, it is better to follow up the patient with the same operator.
Yes, I agree totally. Just in a practical note, I cannot tell you how many rheumatoid arthritis I have converted now with the ultrasound in chondrocalcinosis, because there is a subset of disease that is similar to rheumatoid, and that is not evident with X-rays. And using the ultrasound, you catch it immediately. You see it immediately, and you understand that what you thought was a rheumatoid in reality is a chondrocalcinosis, so that you have to change completely the strategy of treatment. And this is happening more and more frequently in our practice. So just to tell you how much is important to have the probe in your hands, or if you want, to have a very trustable, reliable colleague who knows how to perform ultrasound, to be close to you and to work with you every day.
I think you're lucky. Any other questions? Yes, please go ahead. The microphone here, the microphone's coming.
Thank you. I want to understand if there is close relation between the immune system and all what we talk about.
So the question is, what is the relation between the immune system and autoimmune diseases, generally speaking?
Yes, yes.
Yeah.
This is for the first session, first talk, which will go to the third one.
Now, we'll keep the third one at the end,
Okay,
because this is going to raise a lot of discussion.
Yeah. It is related because this
Yes.
and this affect
Okay.
the immune system.
System. Okay.
So the question is, which is the relationship between the immune system and, I would just say, rheumatoid arthritis in this case? The answer is very simple. If you take a joint, you go inside, you take a small piece of the synovial membrane of this joint, you cut this synovial membrane, you put this on the slide, and you look, you will see an enormous quantity of inflammatory cells invading the synovium. This is the reality. So the synovium is inflamed, and this inflammation is supported by a lot of immunological modification, and in particular the rheumatoid factor that you know probably, the old rheumatoid factor, and moreover the new anti-citrullinated antibodies. And it's very well demonstrated that when the anti-citrullinated antibodies start, the disease becomes erosive. So you know, this is the link between the tissues and the inflammation of the tissues and the immune system, in particular with this autoimmune component of the disease. So you have this all together, and the treatment we are using with specific monoclonal antibodies against only one target that is called treat to target is just targeting one item. For instance, TNF-alpha, interleukin-1, interleukin-6, CTLA-A4 that is a co-stimulator of the behavior of the contact between T cells, macrophages, and then downstream the B cells, or the simple anti-CD20 strategy on B lymphocytes. So you know there are many ways that you can aggress the immune system through these different components and actors in the pathogenetic cascade of rheumatoid arthritis.
Thank you.
Any more questions for Professor Cerinic? Okay, Professor Khair. But a question related to rheumatology, not ENT, please.
It's really a rheumatology. I just want to ask, this is what you call about the immune system. You are the biological treatment you're talking about, or what you are talking about, the methods of treatment for the rheumatoid arthritis. Are you treating this bullet train, which is the immune system, which is eating up the joints, or you are treating the destruction of the joint that had happened by this autoimmune disease? This is one question. The other question is, when do you decide to send the patient to the orthopedic surgeons to say that I cannot help this patient more, as you said in the last slide, that the psychology of the patient. You cannot treat him and you send him to the surgical, orthopedic surgeon. Please, as you know that the advances in knee replacement or joint replacement is becoming very advanced nowadays. So when do you decide to send him to that, I cannot help you anymore, go to the orthopedic surgeon? Good questions?
To a certain extent, not badly. I think you are improving. Better than 2 years ago.
Okay, so thank you. About the surgeon, we hope never to send the patient to the surgeon. Okay, so this is our hope, and we are improving. From 30 years ago when I started up to now, maybe I call the surgeon once a year, twice a year, no more. Why? Because our drugs are very powerful. And our drugs reduce inflammation very rapidly. When you have an infusion of infliximab, the patient is crippled, you infuse him, he wakes up and he walks. So the effect is immediate because killing inflammation is the treatment we need for these diseases, in rheumatoid diseases. So the surgeon is less and less involved by us. But your question is when, at which point I will send the patient to the surgeon. So you have seen the cascade, the behavioral flow chart, phase 1, phase 2, phase 3. In the phase 3, when I start to use this drug continuously and trying to find a way because I'm failing, I'm not able really to control the disease, the surgeon comes into the picture. Why? Because if there is a knee, for instance, that is very active, I will ask the surgeon to clean, to shave the inside of the knee and to take away the synovial membrane just to reduce inflammation. Or I shall ask him to implant a prosthesis to avoid the final degradation and the crippling of the patient. So, you know, this is coming up according to the disease, and in particular, in these 3 phases that I already see how I shall be able to control the disease. If I don't control, I will call him to help me to control the disease, shaving the joint or to replace the joint if it is really damaged. To go back to the first question you were asking about.
You slow down the immune system or you treat the immune system to stop destructing the joint?
That's a tough question. Very tough. Why? Because, as I told you, we are not able to cure the disease. We are able to treat some...
No, this is the point. You are treating or you are stopping the immune system?
We are stopping the immune system downstream, but not upstream. So that's the point, downstream. So we are able to stop. And for instance, the last drug I told you, the denosumab, is dealing with the erosion, is not dealing with inflammation. So the ideal would be I use a treatment for inflammation, I use a treatment for erosion, and maybe, who knows, maybe tomorrow we shall able to combine these 2 treatments. But still, these are downstream treatment. It's the best we can do today. But think that 10 years ago, we had nothing. So the great change in the last decade is that the rheumatologist has turned from having gold salts and antimalarials in his hands to enormous quantity of drugs that are dealing on the disease, that are stopping the disease evolution and changing the quality of life of our patient. So think about workability. They go back to work. They work. Their social life is restructured. What Professor Boverman has shown you is the fact that all this distress, when you treat the patient, after 1 shot, stress is gone because he feels well, no pain anymore, he feels a normal being.
Thank you very much, Marco. We'll move to the second paper. The second paper was presented by Dr. Emil Hanna about gout. Any questions for gout?
Can I make a question? If there is anybody? Yes. Emil, you know, I was curious about the fact of kidney and the stones, and you said that uric acid can serve as a niche where all the other crystals can really stick together and deposit stones. Are you using try to change the pH of the urines to prevent the deposition of stones?
Yeah, I think you're right, because most of the uric acid stones are precipitated in an acidic media. So we better, when we change the urine to alkaline media, the uric acid is less deposited and like this.
Any other questions? Yes? Can we have the microphone here, please? Okay, تفضلي حضرتك. Okay, you want to ask a question? Okay.
Dr. Emil, is there any genetic factor regarding gout as a causal factor for gout? And can we detect early the gout before any signs and symptoms? And what about the impact of the lifestyle on the treatment of gout?
Yeah, thank you, Dr. Muhammad. Actually, there is genetic predispositions for people developing gout. Actually, there is more relations between the genetic people who develop gout and hypertension. The genes even similar like this. Second question. Lifestyle is very important. You know, people need to, you know, for example, you need to lose weight, because obesity is a major factor in people with obesity. They are liable more to develop gout, and also the habits of eatings. You know, some foods, as we mentioned, we need to be careful about it, like using the red meat and the shellfish and beans and other, you know. And drinking more water, yes, is very advisable, you know, because as Professor Marco said now, this uric acid crystals can be precipitated in acidic medium. So drinking much water, this help the urine to get off of these stones.
Can I add something? And you know what? Coke is not helpful in this. Me, myself, I had to stop drinking Coca-Cola, unfortunately, because of stones in the kidney. Cucumber?
I don't know about cucumber.
It contains a lot of uric acid, or it chelates uric acid? Contains a lot of uric acid? Could be. If this applies to cucumber, it will apply to other green vegetables as well. One of the things I found in my patients with rheumatoid arthritis, that almost 80% of them, they drink less than 2 glasses of water every day. And I keep telling all my patients, you have to drink between 1.5 to 2 liters of water daily, irrespective if you have rheumatoid arthritis or not, to be a healthy person. Now the final, sorry.
Hello, my name is Charlotte Kamel, Head of Department of Psychiatry at RCSI Bahrain here. So I thank you, the organizers, for this great symposium which combines mind-body connection. It's great that you include us. And I thank Professor Boverman for his interesting speech. Just a comment, I was very impressed by the way you presented it, and I think I agree with you that causality is not an important issue, because by the time we get our patients, they already suffer from disease. I'm very happy about the final complementary approach to it. And I want to ask you whether you agree that it goes with the principles of motivational counseling, which are courses which are conducted on a wide scale now in the area of medicine. And it goes along the same principles, which is instilling hope and helping patients to modify their attitudes, because compliance issues and organizing their life around, this suffering from a physical disorder is important. So how do you feel about that?
Pleased to meet you. And your question then is how I feel about motivational counseling or motivational enhancement systems, motivational interviewing, the technique of Miller and Rolnick? Is this the question?
Yeah.
I am glad that you brought up motivational counseling. Motivational counseling, or it's sometimes called motivational interviewing or motivational enhancement, is an enormously powerful tool that I, as a faculty member at my medical school back home, devoted a great amount of attention to when I worked with medical providers. And if you have the opportunity to enroll in a motivational interviewing course or take a seminar in it, I strongly recommend it. It will help you motivate your patients to do what you would like them to do. The other thing that it does is it makes that interaction much more pleasant. The basic cornerstone of motivational interviewing is finding a way to take your patients where they're at. Not all your patients see the world the way that you do. Not all your patients put the same emphasis on their treatment that you might. They have other things in their life. And motivational interviewing allows you to work with someone who really doesn't see things the same way as you and helps you bring them to your point of view without causing a lot of disagreement. And it's a beautiful system that was invented for working with patients with alcoholism and drug problems, but it's applicable to any kind of behavioral change. Lose weight, quit smoking, take your medicine, come to the doctor. All of these things have a motivational component. Most patients could benefit from some motivational enhancement. And this is a system that really, really helps. Is there training available at the Irish University?
We used to give courses in Arabian Gulf University to students, final year clinical students.
Great.
And, I'm planning to give it in RCSI.
Oh, great. That's wonderful. Thank you.
You had a question about psychiatry. Can we have the microphone here?
Regarding anxiety, depression, and distress, I don't understand really. It can cause the changes itself, or it affects the feeling for pain or muscle spasm, because stress and anxiety, depression can cause muscle spasm first, and it can decrease the pain threshold. This may be the cause of relieving the symptoms, but it can do something with erosion, for example.
It can do something with illusions?
The erosion,
Erosions.
the process itself. What I mean, the relation is regarding the pain and symptoms, or the process itself.
You mean the disease process itself?
Yes.
I am of the opinion that stress, anxiety, and depression can through a variety of factors, they have the potential to cause erosions, to worsen the prognosis of a rheumatic illness. I don't think that I was able to find the most clear evidence that we would want to understand that. I think that a bit of data that would do that would be, let's say that that rheumatology patients were assigned to a yoga class and then they became happier, and then compared to a control group they had less erosions. I don't think that study has been done. I don't think that we have that level of detail. And so I think at this point, it's a matter of opinion. I'm actually curious what my colleagues who know a lot more about rheumatology than I do would think about this question. Do you think that the stress, anxiety, depression, does it merely result in increased distress and disability, or can it lead down the road to changes in immune function that could have physical problems associated with it?
I think stress and depression can lead to a flare-up in a patient who is in a remission. And this by itself can turn the disease to be more aggressive and more progressive and lead to erosions. But it's a causal relationship that if the patient is controlled, and I see this in many of my patients, any stress which happens during their life, they flare up completely, and it takes time to control and induce a remission for a long time. During this period, an erosion can occur, especially if they have an aggressive disease.
Yes, and now it comes in my mind from the answer that there is no researches or study had been done on this. So what about if international hospital start thinking of doing this research here in Bahrain?
Yes,
Hmm?
go ahead.
This,
You will have my blessing.
No, this is one. And the other one, is it wise if we make combination of a rheumatologist and a psychiatrist in caring for those patients?
Yes, I refer, especially patients with systemic lupus erythematosus who have cerebral lupus.
Oh.
I send them to psychiatrists, and we cooperate. Patients with rheumatoid arthritis who are under continuous stress, like apart from the daily stress, they have extra stress at home or at work. Sometimes I give them something to improve their mood. And the other thing, 40% of patients with rheumatoid arthritis have secondary fibromyalgia. They don't sleep well at night. They wake up in the morning with generalized aches and pains and so on. So I tell them, I'll give them something to calm them down and let them sleep at least 6 continuous hours deep sleep in the phase of the third phase of sleep.
Oh.
And this makes a difference to them. And we have to differentiate, because usually they come and say we have neck pain, and they attribute this neck pain either to the disease, the rheumatoid disease, or to cervical spondylosis. And when you examine and take a proper history, you find that it is secondary fibromyalgia, secondary to rheumatoid arthritis.
Yes. And now this is the last talk because I talk
Go
too
ahead.
much. You may be a little bit personal and helpful. Are you accepting a psychiatric specialist who is 65 years to start this research? Yes. I'm very interested, but I'm geriatric now, 65 years. Think and tell me.
Oh, I'm sorry.
No, think and promise me.
You mean
Either
that?
to say yes or no.
Yes.
Okay, thank you.
Okay, this is the last question, and then we'll have a coffee break.
This is from the sarcastic point of view. We are living now in a global village, and all of us are under risk and under stress, and we are suffering from anxiety and tension. Do you recommend any remedy to avoid the stress as a prophylaxis?
I am a great believer in a number of things that promote wellness, happiness, well-being, even in people who are already well. I think you can always be weller, you can always be happier. I attempt to do this in my own life. I think doctors are notorious for treating themselves poorly, for continually looking at themselves critically, for driving themselves so hard that they actually perform more poorly than they would if they gave themselves rest, relaxation, time with family, sleep, and in particular, exercise. I believe that a practice such as yoga is really, I don't think it's an option personally. I think that everyone should do something like that. I believe that that there are stress management techniques that living in a modern world we need to take advantage of. So thank you for your question.
Thank you very much. I think stress management is very important.